Mm.
Yeah, good evening, all. Welcome to iFocus Online, the 353rd episode, the 28th in the Oculoplasty module. Today, we have none other than Dr. Honavar to speak to us on enucleation and evisceration, the indications, techniques, and complications. Over to you, sir.
Thank you, Sudha. I'll share my screen. So as we moved away from lacrimal, we are going to the socket very briefly before we move to orbit, which is the core topic. So in socket, we have few considerations, one of which is, how to do these surgeries, enucleation and evisceration, which are very common surgeries that we perform, and also orbital excitation, which will be the topic of the subsequent classes, and contracted socket as well. These are three important topics which are important from the perspective of a postgraduate student or a fellow. So today I'll be covering enucleation and evisceration, safety versus optimizing cosmesis. So when we talk about these two techniques, it's actually considered a defeat for an ophthalmologist because you are doing something that totally deviates from your primary goal. In ophthalmology, the primary goal is preservation of eye and vision, and enucleation and evisceration are absolutely diametrically opposite to these two goals, which means that you are destroying the eye. Of course, with a purpose, but this is a deviation, no doubt. And whenever you take such a deviation, you have a solid reason and also a duty or obligation on your part to provide optimal cosmesis to the patient and make these two procedures, which are finally the end of the funnel procedures for the patient, as comfortable as possible and as uncomplicated as possible. If with these two procedures, if you have more trouble than good, then it is really not good for the patient. So the purpose of this talk is to understand why we should do which procedure, when we should not do which procedure, and if at all when we do, how to do it well and achieve optimal cosmesis for the patient. So the challenge in these two procedures is to weigh safety of these procedures versus acceptable cosmesis. Now the acceptable cosmesis is something that is relative. Most of the patients would want a lifelike eye, which may not always be possible because of the limitations in the socket itself or the kind of prosthesis that we have. Some of the prostheses are stock eyes, which really don't make justice to the socket, but custom-made prostheses along with a good implant will provide acceptable cosmesis, if not absolutely matching with a contralateral eye. Now, cosmesis also means two things. One is static cosmesis. When the patient is stable, is not moving the eye, the kind of one glance kind of a cosmesis that you see is static cosmesis, which is absolutely very good with a prosthetic eye. But dynamic cosmesis often falls short of expectations. Dynamic cosmesis is when the patient is conversing or has an eye to eye contact, when he's talking or making gestures, the eye may lag behind the natural eye. Its range of movement may not be absolutely kind of matching with the contralateral normal eye. And that is the reason why many of these patients get kind of disappointed with the results. But if you explain to them that to a certain degree they can move the eye, beyond which they have to actually move the head to maintain symmetry in almost all cases, then they learn it very well very soon. Now let's start with the indications for enucleation. These are some of the indications, standard indications for enucleation. Any patient who has an irreparable trauma with a completely ruptured eye with no visual prognosis, ideally you should enucleate. Evisceration really does not have role here because you may leave some uveal material, especially in a traumatized eye. Leaving uveal material behind would mean that there is a higher risk of sympathetic ophthalmitis. If at all enucleation is not really possible for any reason, because of bleeding, concurrent orbital fracture, etc., or if that surgery is not safe, you cannot give anesthesia, then frill excision is acceptable, where you excise almost nearly totally every bit of sclera along with uveal tissue, but don't really cut the optic nerve. That is acceptable, but not evisceration. So ideally, we should do enucleation in badly traumatized, irreparable eyes. And the second indication is to prevent sympathetic ophthalmia. In a patient who has a painful blind eye or trauma with inflamed eye, then if there is no vision, then ideal surgery would be enucleation. The third indication would be a chronically painful blind eye. So for whatever remote reason, the eye has gone blind and it is painful, it is symptomatic to the patient, patient has photophobia, patient has constant pain, constant red eye, cosmetically not acceptable, then enucleation is definitely an option. Objectionable appearance such as this, patients who have staphyloma can have two options. One is enucleation or evisceration, but enucleation is definitely a reasonable option in patients who have an objectionable appearance by means of staphyloma. Of course, intraocular tumors are standard indications for enucleation, either a melanoma which cannot be cured with brachytherapy or retinoblastoma that is refractory to chemotherapy and focal therapy can also be considered for enucleation. Enucleation used to be a barbaric procedure. This is how it used to be done. You can look at these instruments. It looks as if this picture is from a torture chamber, but that's how it used to be done. There was no other way out. I used to be simply scooped out or pulled out. And from there on, we have actually moved to microsurgery now. Every enucleation or evisceration is currently performed with the same microscope that we do cataract surgery with. And every tissue is visualized before it is cut. Now, there are special considerations for enucleation in intraocular tumors, especially in retinoblastoma and melanoma. You have to do enucleation with minimal manipulation here. You should not unduly press the eye or should not have accidental perforation. You should try to aim for the longest possible optic nerve stump in retinoblastoma. Just to show you this example, textbooks write that 10 millimeter optic nerve stump suffices. In this patient, you can see optic nerve is already involved, it is thickened. If you were to stick to 10 millimeter, you would still leave some residual tumor at the edge of transection, which will actually change the prognosis. If you stretch the length and go to about 18, 19, or even 15 millimeter, now you have a surety of having a negative transection margin, and that changes the prognosis and the need for radiation can be completely avoided. So longer the better when you're dealing with a situation of retinoblastoma. And of course, in melanoma and retinoblastoma, you should avoid accidental perforation by using blunt tip instruments, not really sharp instruments, and not unduly manipulate the eye. And when you pass your sutures through or near the insertion of the extraocular muscles, you should be very careful and you should be at least a millimeter away from the insertion so that you can avoid accidental perforation. Another consideration for retinoblastoma is that, in certain institutes, it is a routine practice to use clamps for the optic nerve. People do clamp the optic nerve with an artery forceps and cut beyond that. People use snares. These can alter the histopathology of the optic nerve, and these are generally avoided. It is also mandatory that you inspect the eye completely post-enucleation and also look at the optic nerve. I'll show you that a little later. And finally, follow the histopathology protocol that is supposed to be followed following enucleation. That's because at least 1 in 2 eyes that you enucleate in India for retinoblastoma have histopathological high risk factors, and it is mandatory for the pathologist to pick up these factors so that adjuvant therapy can be instituted. Otherwise, the risk of metastasis in such patients is 1 in 4. 25% of children who have these high risk factors develop systemic metastasis if they're not recognized and treated properly. Now, going straight away to surgical principles of enucleation. The most important surgical principle in order to avoid contracted socket is preservation of conjunctiva. Now, conjunctiva being the lining layer of the socket, you need as much conjunctiva as possible. You cannot produce conjunctiva, but whatever that is already there has to be retained and optimized. So your peritomy has to be as close to the limbus as possible without unnecessarily excising conjunctiva. Try to avoid buttonholes to the conjunctiva. Try to not traumatize the conjunctiva or the edge of the conjunctiva using fixation forceps or being rough with the conjunctiva. You should treat conjunctiva extremely gently because that is the layer which you'll finally use to cover your implant. Second consideration is that if you are using an orbital implant, you should secure wound closure. Wound closure in one layer is not secured for an implant. Implant being a foreign material, body generally tends to extrude anything that is a foreign body. So in such a situation, it is mandatory that you have 3-layered closure over the implant so that it remains stable and secure in the intracorneal fat. So your dissection should involve very careful separation of the conjunctiva, very careful dissection of the anterior tenons and posterior tenons. Finally, place the implant in the intracorneal space, close the posterior tenons, then close the anterior tenons and close the conjunctiva. So these 3-layered closure will secure the wound completely. And whenever you close the conjunctiva, there's a technique of closure which I'll show you in the video. The third consideration is, of course, you are removing the eye. Now, what about the volume? Volume has to be replaced optimally. And what is optimal volume replacement? Subha, what is optimal volume replacement? When I talk about optimal, what do you mean by that term?
Replacing the lost globe volume as well as prosthesis.
What is the lost globe volume for a normal sized eye?
7 cc.
Okay, so how much do you replace?
4.5 cc.
Why? Why 4.5? Why not 5? Why not 6? Why not 7?
With the implant, we have about 2/3 of the volume replacement, and the rest is covered up by the ocular prosthesis.
Okay, so generally, prosthesis needs about 30% of the volume, right? So 70% of the volume is replaced by the implant and 30% is left for the ocularis. So about 5.9 maximum is the volume of the, 4.9 of is the maximum volume of the implant and 2.1 is the maximum volume of the prosthesis. Why do we need so much space for the prosthesis? Is because it needs to be thick to allow a 3-dimensional kind of a visualization of the anterior chamber, etc. So to do that, you need a particular volume. So about 70% of the ocular volume, 4.9 cc, is replaced by the implant and rest of it by the prosthesis. Now, when you talk about the implant, which implant? This is a question that is often asked. In fact, in the exam, they keep implants for spotters, implants for OSCE, implants can also be a part of table viva. Implants are often asked in the exam. So whenever somebody asks you which implant would you place, what do you answer? How do you answer that? Is there any classification for the implants? Tuju?
Sir, porous, non-porous implants?
That's a very simple classification. Porous, non-porous. Do you want to be more specific? Would you get
Biological
marks by saying that? If you want full marks in the viva for this question, how do you answer this?
Sir, synthetic based on the material, PMMA, silicon.
So based on the integrability of the implant, integrated, semi-integrated, non-integrated, or biogenic.
All right. So based on the material, it can be biologic, biogenic, or synthetic. Based on the porosity, it can be solid or porous. But more importantly, based on everything, the comprehensive nature of the implant, you can classify it as non-integrated, which means that implant is neither integrated with the orbital tissue nor with the prosthesis. There are only 2 structures that the implant can get integrated with. One is orbital soft tissues, secondly with the prosthesis. So non-integrated neither has integration with the soft tissue nor with the prosthesis. Now semi-integrated is one where it is either integrated with the orbital soft tissues or with the prosthesis. So if it is supposed to be integrated with the orbital soft tissues, either you use sutures to integrate it, that is mechanical integration. That means you suture muscles to the implant. Example is that, so let's just finish this non-integrated. So non-integrated would be a silicon or a PMMA ball implant, which is placed in the orbit. So it does not get integrated biologically with the orbital soft tissue, but it is pseudo-integrated because any implant that is placed in the orbit gets what is called a pseudocapsule. It gets walled off by the body. Silicon gets a very thick pseudocapsule, whereas PMMA gets a thinner pseudocapsule. Nevertheless, they are pseudo-integrated. They're not truly integrated. And around the pseudocapsule, there will be some fibrous tissue, which will ultimately make it partly integrated with the orbital soft tissue in an indirect fashion. So in true sense, no implant is non-integrated. Non-integrated is also pseudo-integrated. Semi-integrated is even a silicon implant or a PMMA implant when it is covered by sclera and when it is put into the socket. Sclera gets integrated with the orbital soft tissue because sclera is collagen-rich material. Implant lies within that sclera, which you have wrapped the implant with, and to sclera you attach extraocular muscles that becomes semi-integrated. So the same implant, which is silicon or PMMA, can also be used to cause semi-integration, but it is not integrated with the prosthesis. So semi-integration is a process where the implant is integrated with the orbital soft tissues by covering it with sclera or directly suturing the implant to the extraocular muscle, in which case you use a porous material. So porous materials such as porous polyethylene can be sutured to extraocular muscles, and at the same time, since it has pores, it will also get integrated with orbital fibrovascular structures. So that is also semi-integrated. Now, semi-integrated prosthesis, semi-integrated implant can be made integrated by drilling a hole into the implant and pegging it and pegging the prosthesis to it. So basically, if this is the implant, you drill a hole into it, peg it, and this peg is coupled to a prosthesis. So you can make a semi-integrated implant integrated by pegging it, right? So that is how the whole process evolves. It's not that an implant can be used only in one fashion. Hydroxyapatite, when it is put into the orbital cavity, obviously it gets integrated with soft tissues, but it will not be integrated with the prosthesis unless you peg it. So it is a continuous process. Now, bio-integrated is definitely either porous polyethylene or hydroxyapatite. That means there is biological integration. So this integration is mechanical, whereas this integration is biological. So integration by using sutures directly on, say, for example, there are certain implants which are silicone implants where there will be suture tunnels. So all you do is pass non-absorbable sutures through the extraocular muscles, pass the sutures through the suture tunnels. But extraocular muscles don't get stuck to the implant. What holds it in position are the sutures, right? So that is also integrated, but that is mechanical integration. That is not true integration. Biointegration is when fibrovascular tissue passes through the implant and it becomes part of the body. Biogenic implant is dummies fat graft. So if I made it complicated, let me make it simple. Non-integrated is one where there is no integration with either orbital soft tissues or the prosthesis. Classic example is a mule's implant or a sphere or a ball which is made up of PMMA or silicon classically. These are the two materials. Semi-integrated by design, such as Allen's implant or Castrovio implant, are the implant which can be semi-integrated. They can also be integrated by exteriorizing a part of the implant. So mainly semi-integrated implants are integrated with the orbital soft tissues or with the prosthesis, ideally by a mechanical means. Integrated implants are the ones which are integrated to the orbital soft tissues and to the prosthesis, generally by mechanical means, whereas biointegrated are biologically integrated with the orbital soft tissues and to the prosthesis by a coupling device. Biogenic is dummies fat graft. Is there any confusion with this? No confusion at all, right? So if I show you some pictures, possibly you will understand. This is a textbook picture, whereas this is a mule's implant or a sphere. This is a sphere made up of a different material, but it is nevertheless a sphere, right? So spheres can be made up of different material. The first implant that was made was with which material? First mule's implant was
Glass.
glass. It was a heavy material, whereas silicon does not weigh as heavy as glass. So silicon gets better centered as compared to glass. PMMA is even better. It is lighter than silicon. So PMMA does not sag down by gravity. It remains even better centered. So all these are various examples of spheres, right? So these are classically non-integrated implant. Whereas this is Castroview implant and this is Allen's implant. So what does this have? See, this has these fenestrations for passing extraocular muscles, right? So after having enucleated, you have these extraocular muscles. These extraocular muscles are simply passed, these taken to the other side and sutured. So there is a kind of cross imbrication of extraocular muscles through these holes. So what happens finally? The extraocular muscles will lie like that on top of the implant, right? So the implant will be submerged by the anterior tenons and the conjunctiva, correct? But these have these sharp edges, right? Or these are called nodules or lobules. This will form humps on the surface of the socket. So when the prosthesis is made to fit this, prosthesis goes around these humps, right? This is also a way of doing pseudo integration. So if you have a contoured socket like that, on top of that, if you fit a prosthesis, this is the anterior surface of the prosthesis, this is the posterior surface of the prosthesis. You see this posterior surface goes into the hump that is created. So that will gives you a kind of pseudo coupling. These are all various phases of evolution. But the problem is that because of constant rubbing over these humps, which are tough humps, there will be over a period of time thinning of the conjunctiva in that area, exposure and extrusion. That is the reason why these implants are generally not used. There are also individuals who exteriorize the anterior portion of this implant and then put a prosthesis on top of it. So there is some kind of a pseudo coupling there. So they are using even Castroview and Allen implant as integrable implants. They're mechanically integrated by tying the muscles to these fenestrations to the extraocular muscles, and they're also mechanically integrated with the prosthesis. But the implant is already exposed primarily by the surgeon himself, right? Which leads to infection, chronic inflammation. Infection leads to contracted socket. So all these implants are historical and they are avoided. So currently what is used is this. This for sure, this is sphere implant. This is the most commonly used implant. There was a peak in 70s, 80s, 90s as hydroxyapatite and porous polyethylene started coming up. There was a peak. Everybody started jumping into the bandwagon and started using these implants, but soon realized that these implants have a higher chance of implant exposure and extrusion. So, and finally in late 1990s and 2000s, there was a slide. Now it is settled down to a particular level where it is used only in patients who understand that these implants have complications and are ready to take that risk for the sake of better prosthesis motility. For everybody else and for patients with intraocular tumors and children, we use this. So standard of care currently is non-integrated silicon or PMMA implant for children and adults with intraocular tumors. The reason being, why should you use these implants in children or adults with intraocular tumors? Quickly. Bolo? I'll give you a leading question. Suppose you have enucleated a child with retinoblastoma. You don't know on MRI that there is full thickness choroidal invasion. and scleral invasion. Following enucleation, pathologist tells you that there is full thickness scleral invasion or optic nerve transection involvement. What is the next step?
The radiation has to be done. So
Correct. So when you do radiation on top of an implant which is biointegrated, such as hydroxyapatite or porous polyethylene, what will happen to the implant? What does radiation do to microvasculature of the implant?
it will be extruded because of the
Absolutely, it will impede microvascular integration, fibrovascular integration, and it will lead to a dead implant which has a rough surface. So the next thing that will happen is implant will get exposed or extruded or will become infected. So by doing a silicone or a PMMA implant in a child or an adult with intraocular tumor, you are covering for possible external beam radiation, if not now, even later, right? Second is calculation of dose of radiation is very precise when you use a compact implant. The third reason is that if it is a child and you have done enucleation at the age of 9 months and you have put an implant of 16 millimeter size, child will grow into an adult and that particular implant volume may not be sufficient for that adult. You might want to replace or exchange an implant. You cannot do that if you have put an integrated implant. It is impossible to remove an integrated implant without causing substantial trauma to the socket, which will only accept then a dermis fat graft as a replacement. So if you want to simply exchange an implant, then PMMA and silicone are the ones which you need to put because they can simply be removed and replaced. Hydroxyapatite and porous polyethylene cannot be removed easily or can never be exchanged. You can only put a kind of a piggyback implant on top, like a dermis fat graft on top. So this is the safest implant for a child or an adult with intraocular tumor. Whereas hydroxyapatite and porous polyethylene implants are good for adults who want better implant motility. These two implants provide better implant motility only if hydroxyapatite implant is pegged, and this is a titanium or a ceramic peg, and also porous polyethylene can be pegged with a titanium peg. Only then they give better implant prosthesis motility. If you don't peg it, the implant motility is comparable to myoconjunctival technique implant motility, and they give no additional advantage. So if a patient were to ask you a question, just by having a hydroxyapatite implant and choosing to not get it pegged, would I get better prosthesis motility? The answer is no. Unless the implant is pegged and the peg is coupled to a prosthesis, the patient will not get better prosthesis motility. As compared to myoconjunctival technique, there is a randomized study which is published in ophthalmology, which has compared, it's our own study, where we compared myoconjunctival technique implant motility with porous polyethylene implant motility and found that the implant motility itself is absolutely comparable. Prosthesis motility is a different ballgame altogether because silicone and porous polyethylene cannot be pegged, whereas hydroxyapatite and any of the porous materials can be pegged. So it allows for pegging, but pegging would mean that there is a higher chance of implant exposure and extrusion. Now, this is sometimes commonly asked, at least if not for a resident, this is a quiz question and fellows are often asked, what is the pore size? What is the ideal pore size? Or if you're choosing an implant, for example, if you go to a conference or to an exhibition, you'll find a lot of implants. But if you ask the manufacturer, what is the pore size of your implant? They will not know, or they're not bothered. They're just there to sell the implant without realizing that there has to be a particular pore size for the implant for ideal integration. And for an orbital prosthesis, ideally the pore size should be about in the range of about 300 micron. If it is less than that, there is poor integration. If it is more than that, then again there is poor integration. So the ideal integration is around 300 micron, but there is always a range. All the pores are not equal in size because typically hydroxyapatite is made from coral, and coral being a natural material will not have uniform pore size. There is always a range to the pore size, and the structure of the pore is also totally different. Some pores are circular, some are kind of cavitary, some have microcrystals, some are hexagonal, some are cobblestone patterned. All that is listed in this chart. But basically, you should realize that pore size is an important consideration for integration of the implant. Right. Now, these are the recent advances in integrated implant. Aluminum oxide is something that has come up. Hydroxyapatite generally is not coated. It is like this. It has a rough surface, as you see. So since it has a rough surface and suture cannot be passed through this tough material, we have to cover it with sclera. That's called wrapping of the implant. The problem with wrapping is that once you wrap it, how will the blood vessels reach the implant? Not, right? It cannot. So when you wrap it, you create small windows within the sclera to suture your extraocular muscles, 4 such windows. And on top of that, you cannot completely wrap it. You leave the posterior aspect of the implant unwrapped so that there is egress for vascularization and fibrous tissue from the posterior aspect of the implant. If you leave the anterior surface of the implant unwrapped, then this rough surface will rub against the prosthesis, and ultimately there's a higher chance of extrusion. So anterior surface should be covered with sclera. Now, to prevent using sclera, because sclera is not readily available, the implant come with their own coated material like that. So anterior surface of the implant is coated with something that lasts for a long time. Posterior surface is also coated with something that lasts for a shorter time. Why should the posterior surface be coated at all? That's because how else do you put the implant? These are rough surfaced implants. When you put it, the anterior tissue will be dragged along with it, right? So to ease the implantation, either you use an implant inserter or coat the posterior surface with something which is short-term coating, that to make the implant smoother, so there is no dragging of the tissue through the socket. Anterior tenons, etc., will get stuck to the implant and get dragged because it has rough surface. It is like stabbing something with something which is very rough surface. It will drag tissue. It will cause kind of a trauma. So to prevent that, you need a smoother surface. That's called coating. And this is how a coated hydroxyapatite looks like. You see this anterior coating. This is going to be there for a long time. The posterior coating is smooth, and that's going to dissolve in a shorter time. So once it dissolves, there is egress for fibrovascular structures through the posterior free edge of the implant or free surface of the implant. On the anterior side, you are nearly covered it, and you also provided fenestrations for passing the sutures for attachment of the extraocular muscles. So that is how a newer design of hydroxyapatite looks like. Now, this is the study that I was quoting, implant and prosthesis movement after enucleation. It is the same if you use myoconjunctival technique versus porous polyethylene implant. So these are currently the implants of choice, silicone and PMMA. Least complications, they don't easily get extruded. They're not affected by radiation. There is a study which has showed, in fact, the study used water baths in which each implant was immersed and usual dose of external beam radiation was given, and the biological nature of the implant following irradiation was studied. I think it was done by Karcioglu, and he found that there was absolutely no change at all, not even in a well-cured PMMA implant. There was not even release of monomers following radiation. That means that these implants are non-toxic and remain non-toxic despite radiation. They're easy to image because they are precise. When you image an implant, it looks exactly like that because it is so compact. Whereas if you use hydroxyapatite in implant, there will be a lot of haze around it because of fibrovascular integration. Now, how do you differentiate that from a tumor? Sometimes it becomes very difficult because there is granulomatous reaction around these implants. It becomes very difficult for even a radiologist to identify if there is any true tumor recurrence or if it is just granulation tissue inflammation. Can be exchanged, and it's also 1/50th of the cost of an integrated implant. The next question is what size? Tithi, can you answer this question? What size? Subhav started off once, so we'll come back to the same question. What size of implant?
So usually the axial length minus 2 mm is the size which we choose.
Axial length of which eye?
So of the enucleated eye.
You can't measure axial length of the enucleated eye, right? Easily, because it has a tumor or it is deformed. So you measure the axial length of the contralateral eye, unless the patient is
Monocular.
monocular or has asymmetric refractive error. All right. So otherwise, you measure the axial length of the contralateral eye, and this is what we were mentioning earlier: 60 to 70% by the implant, 30 to 40% by the prosthesis. So this is how you measure. Now you know the volume of a sphere, and if you use that, you can easily calculate it, right? So what is the ideal size of the implant? If you feel that 4.5 cc is the ideal volume that needs to be replaced, ideal sized implant is 20 millimeter. But you cannot always put a 20 millimeter implant because it moons out. Mooning is when you place an implant posterior to posterior tenons, provided there is no intraoperative hemorrhage, right? The implant should snugly sit in its position. It should not move anteriorly. The moment it starts spontaneously moving anteriorly, when you place the implant, like you put it, it just springs back. That's called mooning of the implant. If there is mooning of the implant, that means that it has a higher tendency to extrusion, because even after you close tenons, it will still have a anterior propulsive activity, or it moons out. So it will finally possibly will have thinning of the conjunctiva, or even will have extrusion or a tendency to extrusion. So that is the reason why you should not use a larger implant. Generally 18 to 20 millimeter is used. 19 millimeter implant is also available. So ideally we should use a 20 millimeter implant in an adult, because that is closest. 22 becomes quite big. So 20 or 21 is perfectly acceptable, although it is said that axial length minus 2 millimeter, but practically what we use is this. And if you cover an implant with sclera, you should minus an additional 2 millimeter. Suppose you have a 18 millimeter implant and cover it with sclera, that makes it 20 millimeter. So these are the considerations. So practically what we use is 19 or 20 millimeter. Children 16, 17, 18 millimeter. So for the purpose of the exam, this is what it is. Intraoperative sizer can be used. These sizers come like this, spheres with a rod attached. You simply put in the sizer in the socket, posterior to posterior tenons, and see whether it easily goes in and fits snugly. If it doesn't easily go in, then obviously you can use a smaller sizer. That is actually theoretical. You don't really use this sizer, but you actually put the implant which you feel is best for the child or the patient, and see if it moons out. If it doesn't moon out, that is the perfect size. If it is small, then you can replace it with a larger implant. So all this is done intraoperatively. But if you really want to get an idea, then axial length minus 2 millimeter, this is called Caltrider formula. This will give you a broad guideline, but you undersize that by a millimeter or so, and deduct 2 millimeter for the wrapping material. Where to place the implant? This is not a controversial question at all. Everybody has their own views, but the most ideal position for an implant is posterior to posterior tenons, right in the fat compartment, right in the intraconal fat. That is where the implant should go. It should not lie anterior to posterior tenons. It should not lie anterior to the anterior tenons. That is a very dangerous position. It should always be put posterior to posterior tenons, right into the muscle cone, because then it will have 3-layered closure. So these are various positions of the implant. You can see that this is the most secure position, anterior to posterior tenons, right within the fat. Posterior tenons, anterior tenons, and conjunctiva are the 3 layers that close it, and that implant lies very compact and very nicely in the intraconal space, surrounded by extraocular muscle, just like a normal eyeball would do. So the standard surgical procedure would involve first peritomy as close to the limbus as possible. That is followed by dissection of the tenons in oblique meridia between the recti. The first muscle that you would hook is the medial rectus, right? Because it is
the closest to the insertion.
closest to the limbus, right? Insertion is closest to the limbus, followed by inferior rectus, followed by lateral rectus and superior rectus in that order. Then superior oblique, and last of all, inferior oblique. Once the muscles are hooked, the first suture that you pass is just short of the insertion. That is a 4-0 silk tag suture. Beyond that, 6 to 8 millimeter distally, you pass a 6-0 Weichel suture. Then cut the extraocular muscle either with scissor or cautery in between these two sutures, leaving certain amount of stump. This stump is important. For example, if this is the extraocular muscle that you're going to cut, this is the Weichel suture, this is the silk suture. Don't cut it close to the silk suture because muscle fibers are vertical and your suture is horizontal. So it will easily come out, right? So you need to have a stump on either side to make your sutures more tectonically reliable. Okay. Once you're disinserted the extraocular muscles, all the 6, then you start the process of enucleation. Anyway, I'll show you that in the form of a video that is even better. This is, you can see the video, right?
Yes, sir.
Okay, fine. This is a 4-year-old child with retinoblastoma where we are doing this technique. And this is the myoconjunctival technique where we start with a small lateral canthotomy, about 3 or 4 millimeter lateral canthotomy. Follow that with 360-degree peritomy as close to the limbus as possible. Note that the conjunctival scissor that I am using is blunt tip. It is not sharp tip. This is to avoid accidental perforation to the eye. Oblique meridian sternum is dissected. So this dissection goes quite posterior. Then tagging of the insertion of extraocular muscle. Note that I am at least a millimeter away from the insertion. 6 to 8 millimeter distally, tagging is done with a 6-0 Weichel suture. Then muscle is disinserted. All the muscles are treated similarly. That's the superior oblique simply disinserted. Inferior oblique, being a fleshy muscle, needs to be cauterized and disinserted, otherwise it will retract bleeding. Once all the 6 muscles are disinserted, if you want, you can make a small conjunctival relaxing incision, then prolapse the eyeball through the blades of the speculum. This is very important because this puts the optic nerve under stretch and you don't have to pull on these sutures, right? So the moment you prolapse the eyeball through the blades of the speculum blades will hold the eyeball from prolapsing backward, and it will already give you a certain amount of stretch to the optic nerve. You don't have to pull on the sutures too much. Then the sutures are used only to change the direction of the eyeball and not to really pull on the optic nerve. You don't have to make it straight. Right. Then you take this 15-degree curved tenotomy scissor and go in a closed position and strum the optic nerve. So basically you're taking the tenotomy scissor and going on strumming the optic nerve till you reach the orbital apex, right? So that will be perceived as a hard stop. There is bone there, orbital apex. Now, once you reach the orbital apex, you should not cut there because you are cutting, since you're going from the lateral side, you're cutting through the structures that pass through the superior orbital fissure. And if you cut through the superior orbital fissure, there will be immediate brisk bleeding, and also motility will be immediately lost because you have cut the nerves that pass through the superior orbital fissure, right? So your cut should be at least 2 millimeter above the superior orbital fissure. The next step that you do after hitting the bone is that you lift the scissor in air by 2 millimeter from the orbital apex, engage only the optic nerve. So the scissor opens after you touch the orbital apex, the bone hard stop. The scissor is still closed. Then you lift the scissor by 2 millimeter, strum the optic nerve for the one final time, open the blades of the scissor just adequately. So how much ever you open at the tip, right? For example, you open so much at the tip, that will be shown here as well. So how much ever you open, this is almost equal to the distance between the 2 blades of the scissors, right? So you know exactly how much of scissor you have opened, and it should be not larger than the caliber of the optic nerve. You should engage only the optic nerve. Otherwise, if you open it too wide like this, what will happen? You'll be cutting through all the orbital soft tissues, which will again cause bleeding and disruption of orbital soft tissues. Your aim is to cut only the optic nerve and nothing else. Okay, so that is the step that is being performed here. Only the optic nerve is cut. And along with the eye, nothing comes out. Only the optic nerve comes out and no fat comes out. Length of the optic nerve, nearly 20 millimeter without any effort. Posterior tenons held up and implant is placed posterior to posterior tenons. That's the posterior tenons that needs to be securely closed with 6-0 vicryl suture. It may look thin to you, but it is still a very nice tissue to close. Then the myoconjunctival technique, where each extraocular muscle is sutured just close to its respective fornix. The tag sutures of the muscle are used to do this step. All the 4 extraocular muscles are sutured to the respective fornices. Then finally, anterior tenons, thick juicy bites of anterior tenons are sutured with multiple vicryl sutures with minimal gap. Then finally, conjunctival suture, which is a key pattern suture, just like the suture that you use for a limbal-based trabeculectomy. Conformer, 26 millimeter, or any snugly fitting conformer, and a suture calcigraphy. That completes the process. So all these steps are very important. So the next question that is often asked is, do I go from the medial side or the lateral side, and what is the change in the procedure? What is the change in the instrument that you have when you go from the medial side and when you go from the lateral side? Subha, do you want to answer this question? Shefali, you can jump in anytime to protect your brothers and sisters.
But we prefer to go from the lateral ends, huh?
Why?
Lateral side gives us more space for maneuvering the scissors through it.
Okay. But somebody wants to do medially. What do you suggest? What instrument he or she should use?
It should be a straight scissor.
Yeah. So medially, since the orbital, that's the picture shows, no? The medial orbital wall is straight, lateral wall is at 45 degree, optic nerve is here. If you use from the medial side, it has to be a straight scissor. Otherwise, if you use a curved scissor, what happens? You'll be cutting the optic nerve short. You'll be cheating the optic nerve stump, correct? Because curved scissor will not reach the orbital apex easily, right? So if you use a straight scissor, then you can get a long stump from the medial side. For the lateral side, the best is a gently curved tenotomy scissor that will reach right there. So if you use the tenotomy scissors that I have in my set, 15-degree curved tenotomy scissor, you have to really make a lot of effort to cut through the superior orbital fissure. Unless you really want to cut it, you won't cut through the superior orbital fissure. That is the reason that scissor is there in the sets, right? It is a safety scissor because you have to really angulate it like that to go dig into superior orbital fissure, which is very difficult for anybody to do, you know. So that's a safe scissor. So the scissor is different. Then, of course, what you need to identify is the length of the optic nerve and also the fact that the optic nerve sheath also to be inspected for perineuritic infiltration. You should look for the regularity or the shiny nature of the optic nerve sheath. Look for nodularity, look for adherence of the optic nerve sheath, look for induration of the optic nerve sheath, look for segmental dilatation of the optic nerve sheath, look for vascularity of the optic nerve sheath, look for discoloration of the optic nerve sheath. All these have to be marked. If at all there is an area of the optic nerve sheath that looks very grossly abnormal to you, just ink that area just before it begins. For example, if this part of the optic nerve looks abnormal to you, then you simply ink the anterior edge of that and tell the pathologist to be very careful with this portion of the optic nerve. He can actually breadloaf it and tell you whether there is any skip lesion in the optic nerve sheath. So just the surgery will not help. Being the surgeon, you're also responsible to red flag these areas to the pathologist. Otherwise, the pathologist will not understand. He is not there in the theater. He has not seen the MRI scan. You have all the information and you have to tell the pathologist. This is in the interest of the patient because you want the best of histopathological risk factors. Nobody is going to tell you that unless you ask for it. Their job is to diagnose retinoblastoma, but have you told them where to look for what, right? So optic nerve sheath inspection and also optic nerve end inspection is very important. Generally, when you hold the eye like this, optic nerve falls flaccid like it. That is that clinically indicates that the optic nerve is not infiltrated. But when you hold the eyeball, the optic nerve does not fall flaccid and is quite erect like that. That means that optic nerve clinically is infiltrated. Pathologists may say something different. But if the optic nerve is rigid, then definitely there is optic nerve infiltration clinically. If the optic nerve sheath is adherent to the optic nerve, it does not move like a sleeve, then clinically optic nerve sheath is infiltrated. So all these are the pointers. Next thing is to look for the pointers on the eyeball as such. Any indurated sclera, any bluish thin sclera, any thick sclera, any vascularized sclera, any dilated vertex vein, all these will have to be marked for the pathologist to take sections through and get the high risk factors. Now, this I already mentioned long optic nerve stump, which is a major criteria for enucleation, lateral canthotomy, and relaxing incision in the conjunctiva. Make sure that all the extraocular muscles are transected completely, not even to leave fibers attached, some fibers uncut. Prolapse the eye and use traction sutures, less traction sutures, more of prolapse. Avoid enucleation spoon and scissors because they occupy a lot of space, and space is at premium in the orbit. So if you don't use this hardware, then you have a much better chance of getting a long optic nerve stump. Use tenotomy scissors, gently curved tenotomy scissors for the lateral approach and a straight scissors with a blunt tip for the medial approach. Preferably lateral approach, as you pointed out, it has more space. Strum and just cut short of the apex by 2 millimeter. And in critical cases where you have to reach the orbital apex and get the nerve at the orbital apex, because the radiologist has told you that optic nerve is involved for 17 millimeter and you have only 20 millimeter of the optic nerve, and you want to make sure that you get the entire 20 millimeter, then you can even do lateral orbitotomy and go exactly to the orbital apex from the lateral orbitotomy bone cut and cut the optic nerve right there. So you have all these devices to get a long optic nerve stump. So the myoconjunctival technique, hope this video plays. Yeah, this patient has been operated by myoconjunctival technique. You can see the implant motility, right? Look at this. This is the kind of implant motility you can actually achieve by doing a good myoconjunctival technique. And if you compare this with porous polyethylene, it is absolutely going to be the same. Right? If you really want to measure implant motility, this is the device that we use. This is a slit lamp based device where there's a vertical and a horizontal scale, and you can measure the implant motility. This was the device that was used for the study that I mentioned. This is one more similar situation. You can see the implant motility in an adult patient with myoconjunctival technique. Good implant motility, almost symmetrical with the. You can see the prosthesis motility lags behind because the prosthesis is hindered in horizontal motility by the canthus, medial and the lateral canthus. You can't truncate the prosthesis. If you truncate the prosthesis, it will fall off or it will get decentered. Truncation of the prosthesis to improve motility is possible only if it is pegged. So peg will stabilize the prosthesis and you can truncate it. What does truncation mean? If this is the palpebral fissure, medial canthus and lateral canthus, prosthesis is truncated just short of the medial and lateral canthus. So it will have so much space, more space to move laterally and medially. And that is possible only if you have stabilized the prosthesis with a peg. So pegging has that advantage, whereas non-pegging does not have the advantage. And static cosmesis is guaranteed. That's the enucleated right eye with prosthesis. You can give them really great static cosmesis and dynamic cosmesis also. What are the implant wraps? Sclera, preserved or autologous, is a very good implant wrap. Sclera is collagen-rich material. You can also use other collagen-rich materials such as pericardium, dura, or fasciolata. And synthetic materials that can be used as implant wraps are polyglactin mesh or vicryl mesh, or PTFE, which is polytetrafluoroethylene. So these are the implant wraps that can be used to wrap the implant. And why do you wrap the implant? To make it easier to slide into the orbit, to attach extraocular muscles by means of sutures, or to make the implant integrable with the orbit, otherwise non-integrable implant. So these are the reasons why an implant wrap is used. Other reasons why an implant wrap is used is to minimize the chance of extrusion or exposure. For example, if you find that the anterior tenons is hardly there in a patient where there has been prior trauma or a retinal reattachment surgery where you're enucleating. You find conjunctiva is very bad, anterior tenons is very bad, posterior tenons is all scarred. How do you ensure that the implant doesn't come out? You can use an anterior wrapping material for sure. So when you wrap the implant, you can completely wrap it with fenestration windows that I earlier mentioned, which will allow for suturing of the extraocular muscle and also fibrovascular integration, or you can use a scleral cap. Now, this is a nice technique of scleral cap. Whenever I used to use, now I don't use porous polyethylene implant, I would use this scleral cap technique. So what does it do? It simply sutures a disc of sclera, which is 16 or 18 millimeter on the anterior surface of the implant. Why is it required? Because otherwise, how are you going to suture the extraocular muscles to the implant? This implant is very tough. Unless it has suture tracks, you cannot suture extraocular muscles, and the current generation implant actually come with suture tracks. And that's a video that shows the scleral cap technique. Enucleation has been performed. Now, sclera is cut from a donor sclera. This is hand fashioned. We used to sit and do all this earlier for no reason, just because it was in fashion. Now we have this is called you. I'll just stop and show. This is a very nice technique. If you ever use porous polyethylene implant, I don't know why is it not going back. Yeah, so you should put it in a large caliber syringe and remove all the air from it. So you just put saline into the syringe and suck with the tip of the syringe occluded. So all the air in the implant will come out into the syringe, and that will be replaced by saline, balanced salt solution, normal saline, whatever. What does it do? It enhance the integrability of the implant. If there is air, air is a barrier. If the pores are filled with air, then fibrovascular integration is slower. So this is called saturation of the implant. And once the implant is saturated, this is done outside before we put the implant in. We suture this disc of sclera to the implant. Once you put it in, it is impossible to pass suture through it because it's a tough material. Astigmatism is never a problem. You don't have to be absolutely radial. Center of the implant is marked. That's the implant inserter, which is a plastic inserter with a vertical cut. It's put posterior to posterior tenons. Implant is placed within this inserter and simply pushed in. As you push the implant in, the moment it clears the anterior orbital rim, the inserter is slid out. Right? It has a split, so it comes out through the fingers. And you know the center of the implant. So each of the extraocular muscles is sutured to the sclera. The center is the center of the implant, that violet dot. So it's a nice technique. It's a very nice technique to see and watch, but for the patient, it really does not do much. It adds half an hour to your surgery. You charge 10 times your normal surgical charges, but at the same time, it really doesn't matter to the patient because finally it's going to give the same motility. So peg or not to peg, these are the pegs that are available: ceramic, glass, and titanium. Now the problem with pegging is always done after checking implant vascularization following enucleation. So you have to do a contrast enhanced MRI, or you can empirically peg after 6 months. But ideally, you should do a contrast enhanced MRI and make sure that the entire implant is enhancing. That will ensure that it is vascularized. Only when it is vascularized, you drill a hole into the implant and use this peg. And then the ocularist will fit in a prosthesis, which will get contoured to the peg that you have put. So this is a titanium peg that has been used, but you can use a ceramic peg also. Now, complications are wrong eye, obviously. So this is something that you must avoid. Whenever you are enucleating, it is the surgeon's responsibility to identify the eye. Dilated examination of the eye on the day of surgery, on the table, after giving anesthesia is mandatory. After having identified the eye, don't leave until the draping is complete, because mistakes can happen at any time. In front of you, without you getting distracted, 10 people not shouting in the OT, 20 warm bodies roaming around like headless chicken in the OT. You have to concentrate on on the eye and make sure that the nurse drapes the eye, that is the correct eye, not the right eye, the correct eye, right? So nurse drapes the correct eye. Your mark that you have used to mark the eye, always use double marks and color coded: red mark for the right eye, green mark for the left eye, never to change, and also use a pen ink mark. Both the marks should be visible through the drape, and then only you go and scrub. Never scrub before, right? So hemorrhage is not a major problem with all these electrosurgical devices. Hemorrhage is hardly a problem unless the patient has trauma or infection. Implant migration and extrusion has also become a story of the past. Very rarely does it happen. Volume deficit is a problem because children grow into adults and their volume may not always match, and you can always replace it. Contracted socket will deal in the next class. Eyelid malposition is hardly a problem. These are some of the older exposures where hydroxyapatite and porous polyethylene have been used. You can see real bad exposure. Melt of the conjunctiva. This is absolutely avascular. There is a way to salvage it. You can start drilling from the anterior surface. For example, if this is the implant and this is all vascularized and this is avascular, you drill the implant until the implant starts bleeding. That means you have reached the area which is vascularized. Then you use dermis fat graft or a mucous membrane graft to cover that anterior surface of the implant, and conjunctiva, the rim is already there. Or you can use a Hughes flap kind of a thing where you take a tarsoconjunctival flap or a conjunctival flap from the upper lid, and if you want, you can take a similar flap from the lower lid and suture it on top of the defect, because that is vascularized. It's like a pedicle graft. So that can be used. There are many ways to repair an exposed implant. That's not a problem, but you should avoid exposure. In silicone implant, there is a chance of migration. Migration happens if you have used a smaller implant or a larger implant. Both can migrate. And more importantly, if your suturing in 3 layers is inadequate, if you're not placed the implant posterior to posterior tenons, migration is a possibility. Larger implants, the reason for this implant to extrude is because this child has received a 22 millimeter implant, which is far larger than what he deserves. All right, so that's the end of enucleation. I think we are run out of time. I'll cover evisceration along with contracted socket. All right. So questions? I thought I would finish both in an hour, but this is what happens when you don't answer my questions. Yeah, questions.
So, first question, if I might ask, sir, regarding the pegged implants. So, do they come as is, or are they manufactured separately based on at that time?
No, pegs are always ready-made. Pegs are ready-made. There is a small drill machine that is used to peg these implants. Pegs are ready-made. There is nothing new in pegs. Pegs are available in the market. You simply buy these pegs, but the size of the peg may be different. Depending on what your ocularist wants, you can peg 4 millimeters, 6 millimeters, whatever is the size of the peg. In fact, it also depends on the material. Titanium peg come at a particular dimension. Ceramic pegs come at a particular dimension. When you use a porous polyethylene implant, the typical peg that is used is titanium. Whereas hydroxyapatite implant, ceramic is used. So whichever the peg you use, it will be standard peg. You simply have to drill the implant, center the implant. So basically, in the neutral position with the other eye looking in primary position, you measure the center of the implant, mark a dot, use a cautery to denude conjunctiva in that area, use a drill which goes into the depth of 5 to 6 millimeters, and to know how deep you have gone, you use the pegging kit also comes with a small plastic or a wooden stick. So you insert that stick into the drilled hole, right? Like that vertically, and then see how deep it goes. So if it is already deep enough, say 6 millimeter, or you can use a drill with a stop. So drill with a stop is that, okay, you have gone 6 millimeter, it stops there. So you already know that you have drilled 6 millimeter. Then you put in the peg. And once you put in the peg, you can still cover the peg with conjunctiva and let it heal for a few days. Then you can extrudize conjunctiva. That's one technique. Second technique is primary pegging, where when you put the implant itself, the peg is placed. But for that, you have to be very sure of the implant centration, right? Peg is placed after few months. You simply get hold of the peg and burn out the conjunctiva around it, on top of it. So the peg gets exteriorized. There are two ways of pegging. One is primary pegging, second is secondary pegging. But it is hardly done these days. This is what used to be done. We're spending a lot of time. But the chance of implant infection, implant extrusion are much higher if you are pegged. 20 to 30%, and you cannot take that risk. If you're doing, say, 2 enucleations a week, right, 10 a month, then after a few years, you'll have 2 DFGs a month because your implant is extruded or exposed. How does that sound? 20%. Right? If you're doing 10 enucleations a month, after a few years, you'll have 3 DFGs a month. You'll add to your surgical volume by doing pegging, because 20 to 30% is the exposure extrusion rate. You're creating volume for yourself, which is good, but which is also bad. Right? So it may not be as high as 20-30% in everybody's hands, but even if it is 10%, 1 in 10, why do you want to take that chance? But in a highly motivated patient who wants Cosmesis at any cost and is ready for that risk, you can still do it. Technology is very simple. It is available. Our ocularists can do it. If you get a patient who wants that, definitely, why not? We should never deny patients, whatever the benefits that they want to get. But having explained that, it has a higher chance.
The next question is, sir, what is the proper method for management of extruded implants or implants which are impending extrusion is we can predict?
So if it's an early exposure, say example, you've done a silicone or a PMMA, and at 1 week or 10 days, you find that a part of the implant is exposed. That's mainly because of the suture. Either your gap between the two sutures is larger, or there is a small infection and there is a gap in the conjunctiva in the area of the wound, right? Or the sutures have simply given way. And if you find that there is no tension on the conjunctiva, you simply resuture it, freshen the edges and resuture it. But when you resuture, don't resuture edge to edge because it will tear through. Always use a horizontal mattress suture. So suturing is one. If it's a 2 millimeter kind of a exposure, 3 millimeter, I would glue it. Right? I would harvest a small bit of conjunctiva from the upper fornix, which is an innocuous area, or from the upper palpebral conjunctiva, 3-4 millimeter bit of conjunctiva, and glue it with a seal glue. It will stay and it will heal very nicely. If it's a, say, 6 or 7 millimeter exposure and conjunctiva is tight, you cannot undermine the conjunctiva. You don't want to take out the implant. You don't want to undermine the conjunctiva because it will disturb the wound further. Then you can use the Hughes flap kind of a pedicle graft from the upper palpebral conjunctiva. There are many ways of suturing. Or if you find that the implant is large and that is the reason why it is gaping, you can easily make a nice, decision tree out of this, right? If the implant size is larger, you simply exchange the implant. If somebody has put a 20 millimeter implant, that can happen because of wrong packaging also. So you see, we always measure the implant on the table. We use a caliper to measure the implant. That's because there is chance of wrong packaging. Just like IOL powers can be wrong, implant sizes can also be wrong. Anybody can be wrong at the time of manufacturing, packing. So it's your responsibility to measure the implant. So if you are having a larger implant kind of a situation, you can always exchange the implant to a smaller one and then suture it. So many ways of doing it. But late exposure is always a problem. Late exposure means that there is something mechanical that is going on, not infection. If there is no evidence of infection, if it is mechanical, then you're dealing with it. Either exchange the implant to a smaller one, create flaps and suture the conjunctiva. There are very many techniques to create flaps. Like if you have a central exposure, You can go 6 or 10 millimeter higher than that area of exposure, incise the conjunctiva on both the sides of the exposure, bring it together. So there is a relaxing incision that is given higher, and that area which is denuded because of the relaxing incision can also be always be uh, repaired with an amniotic membrane. So there are many ways of getting conjunctiva together. That's generally not a problem. But with hydroxyapatite and porous polyethylene, it's very difficult to suture or even repair those exposures. It's difficult, it is possible, but it is definitely difficult.
Sir, if we have removed the implant and there is an infection, how long should we wait for a secondary implant after the infection settles? And
Yeah, you should not be in a hurry to put the implant. Once you're sure that the infection is gone, you can always go back and find place for the secondary implant. I would, but at the same time, while waiting for the healing to happen, infection to go away, I would definitely put a conformer. Conformer is mandatory. In any situation, if you lose your phonesis, it is a compounding problem. The moment you have your phonesis all nice and well laid out, implant exposure, implant exchange, nothing is a problem. But your phonesis are also gone, then it becomes a case for dummy fat graft. So secure your phonesis first and then do whatever you want. Then you take your time.
So one more question, sir. Certain cases there is enucleation is done elsewhere where implants are not put. In such cases, how do we ensure proper fitting of COP or a good cosmesis later on? Is there any intervention we can do later on?
That's the topic of the next class, contracted socket. We'll deal with it.
then I have a practical question. If suppose the optic nerve that we cut is not adequate, or if we find that when we cut the optic nerve, it's still thickened where we have cut, if suppose we get a 14 millimeter, how do we go back and retrieve the nerve, and how do we send it for histopathology and any additional management steps that
actually, I like doing it. I want to be called someday, that I have a long, short stump, come and get me longer stump. Well, you use ribbon retractors, 2 or even 4, right? And you can actually palpate the nerve with your little finger. It's looks little gross, and yes, you can go back and get a much longer optic nerve stump. You can get the second length of the optic nerve, 8, 10, 9 millimeter. You simply have to visualize the tip of the cut optic nerve in the orbit. You hold it with a forceps, then you go back with a scissor, with a tenotomy scissor. Again, follow the process of strumming the optic nerve, go to the orbital apex and cut it there. You will get a longer optic nerve stump, but visualization is the key. So your hemostasis has to be good. Use brimonidine drops, whatever, that you use to decongest. Make sure that bleeding is completely stopped. Use a good microscope. Focus it well. No hurry. Use those ribbon retractors. Retract all the soft tissues. You will visualize the optic nerve with, when you go with the suction tip as a tissue retractor, keep on doing suction for this microbleed, you will see that pearly white optic nerve edge. Immediately grasp the edge of the optic nerve with a forceps, pull it anteriorly, go with the tenotomy scissors, and you'll be able to get that additional length.
And so if that optic nerve cut that we first made, if it comes out to be positive, the optic nerve resected end, does it amounts to
any resectional positivity would mean child would need radiation.
That's it.
Thank
you. I had a question, sir. So when during enucleation, if you were to accidentally perforate a globe, lamellar versus a full thickness perforation, then how do we deal with it? Does that become?
That should not happen. That should not happen. But that can happen in one situation. Suppose you are doing enucleation in a, say, trauma situation or infection. That can happen. No trauma because there might be excess bleeding and you may not be in control of the situation. Infection because the sclera is already tectonically bad. So then, or a necrotic tumor also. So retinoblastoma, when you're operating, if there is sterile orbital inflammation, you should control it. Or it's even justifiable to give neoadjuvant chemotherapy, let the eye go into a good atrophy or phthisis, then enucleate. So that is something that you want to do. But if that happens, then you have to deal with it. You have to go back and get everything out. You cannot leave part of the sclera behind. That is not good, because part of the sclera will also mean that you have left uveal tissue behind, which may cause sympathetic ophthalmia. And if you left part of the tumor behind, it will definitely recur. So take your time and get the entire thing out. It's possible. I have heard of situations like that. I've got calls during surgery from patients, the surgeons, that they had this problem, but they've always succeeded in taking out the entire sclera. It's not that they have left things behind. Surgery has complications, but you should know how to deal with it and never close leaving part of the sclera behind. That's the only advice I can give.
So, and how do we retrieve a lost muscle? Like after
Why do you
having,
need to retrieve a lost muscle?
okay, to have a better motility in that.
It's the easiest thing to do. Hold the anterior tenons. Suppose you have lost the medial rectus during enucleation. Hold the anterior tenons, pull it medially. Hold the posterior tenons, pull it laterally. You will find the tunnel. Go into the tunnel, you will get the muscle. Next time I can lose all the 4 muscles and get it back. You ask me to do an enucleation next week, I'll show that to you. It's so easy. It is so easy. Muscle is never lost. Muscle is always in the tunnel. And the moment you follow this technique, inferior rectus is lost, pull the posterior tenons superiorly, pull the anterior tenons inferiorly, exactly at 6 o'clock. Under microscope, you'll see this brown, pink, fleshy thing, and that is the inferior rectus. While it is still in the tunnel, pass a suture, take a good bite, and you have got it back. Never difficult. Or kuch? All right. Thank you so much. Sunil must be cursing. It's 9:50.
Thank you so much, sir.
Thank you, sir.
I miss Hyderabad.
Come back.
We'll visit soon.